Okay, good morning, everybody. It looks like it is right at 10 o'clock Central, so I think we'll go and get started for our webinar today. Welcome, everybody, to our December 2025 WPS Medicare Audit Provider Webinar. This is the fourth one of the year, of course, and today we have quite a few different topics, but before we get into the agenda and the materials, I just wanted to go through a few housekeeping items. There is one thing new for this webinar regarding the, sending the certificates out and everything. Last webinar, we talked about registration. I added the registration requirement in the hopes that the listings, the attendance listing I would pull from WebEx would be cleaned up because there was something that happened early this year, I should say, where, as you can see in this screenshot, many different attendees, if they didn't sign in with their name and their email address, they show up with a generic email address, just a generic WebEx email address, which of course won't work. I won't be able to send anything to that. So we added the registration requirement to allow people to kind of pre-enter their name and their email address instead of having to do it when they log in. I thought that would solve the problem, but with our last webinar, I still found that, and this is a screenshot from the last webinar, that there was still, it was a little under a third of the attendees still didn't have the email address. So what I'm going to be changing this time is by the end of today, and I did this with yesterday's webinar as well, but by the end of today, I'll pull this listing, identify the email addresses I can see that are actual email addresses, and I will send out just a very brief confirmation email to let you know that, yes, I have your email address. I'll send the certificate out, and of course, you'll get the materials. So what I'll tell you, if you don't receive the email by the end of the day, so for example, if you come in tomorrow and you haven't received that from me, if you're interested in getting the certificate and the materials, just send me an email back to this email address or my individual email address, and that way I can add your email address. I can take that as confirmation that you attended, and I'll send everything out. There is one other thing I noticed even yesterday. Even though I had somebody's email address, I still get bounce backs from various providers, other people, and not a whole lot I can do about that. I don't know if it detects it as spam. I think some of them say that. So again, if you didn't receive that from me, just send that email, and hopefully it'll allow me to respond at least without bouncing back. So that's just a little new thing there. And in the email that you send, just say something like in the subject, attended, well, it'll be 12/10/25 webinar now. Just say something like that, and then you don't need to do a body in the email or anything like that. That way I can get you the information and get you the certificate. So the standard housekeeping items we have are just that I will send an email. So it'll be the second email I send once I have everybody's email address. That'll have the YouTube link for the recording, the PowerPoints, the copy of the agenda. You might have already received some of that, but I'll still send it out again just to make sure everybody is caught with that. Now, the attendance certificates, there will be a generic attendance certificate in that main email. If you happen to need a personalized certificate with your actual name on it, then just let me know and I can respond with that as well. The other reminder is that we do have a survey that we send out, and we'd certainly appreciate if you can take the time to take a few minutes to fill out that survey to give us some feedback, give us new topics for agendas. The one reminder, though, is that no MAC staff can take these surveys, whether it's WPS or any other MAC. We're not allowed to do that. So this is only for providers, consultants, home offices, anything like that. Now, I'm also right now going to in the chat area, I just pasted that survey link, so you can pull it from there as well. And I'll do that at the end of the session also. This is the survey link you have in your PowerPoint as well. And if you like the QR codes on your phone, here you can use this. You can either do it right now or get it from the PowerPoint there. Before we get into the agenda, just one last thing. So the way we've handled any questions in the past is if you have them, feel free to type them into the chat area right when we're talking about that topic. You don't need to wait till the end of the session to bring them up. I have the chat box opened up on my other screen so I can see them and we can just address them on the fly. Of course, we'll still have time at the end of the session if you want to ask questions then as well. With that, let's go ahead and get started on our agenda. So pretty much every webinar we have starts off with a brief topic of S10 uncompensated care audits, just the things that have been updated. I did shorten this a little bit this time. We're at the end of the year. Things are pretty much wrapped up or almost wrapped up for 2025. But I did want to talk about a few things we're changing for next year, just to give you a heads up on that. And then just a couple of important reminders on certain things that have been confusing. Provider-based physicians, we'll talk about a few things there. Home office and related party costs, including the new cost statement form set. A little bit of capital-related costs, some issues there. One issue with organ acquisition costs. One thing I do want to mention is this is a topic that, of course, only applies to a relatively small number of providers. That being said, it's a big topic. It's really complex. I want to start bringing in just small bits of this topic into our webinars. I'm not going to spend, the majority of the time because, again, it's not relevant for many providers, but I do want to just bring a little bit into each, or not necessarily every webinar, but a few webinars here and there to kind of build it up. We'll talk about nursing and allied health programs, specifically this time with the cost reimbursement side of things. Last time we talked about the add-on payment. And then I also brought in a new topic that'll be in every webinar. It's just miscellaneous issues. My goal there is that if anything happens to come up last minute between the time when I first send the agenda out and when we have the webinar, this is a place I can put them into. And we have a great example this time. I have a few updates on low volume and MDH, both of them, and then a couple RHC updates, just real quick hits there. And then as with all sessions, we'll wrap up with just a review of the resources we have and YouTube, webinars, website, things like that. So with that, let's go ahead and get started on the S10 uncompensated care audits. And I'm going to start off with the change that we're talking about for our process. Now, this is just WPS. We're basically starting a little bit earlier than we have in the past, and it'll give providers more. The other thing, well, let's take that first. So 211 to 310. These letters we're going to send out on 1/9 of 26, so right after the new year, and we're going to give you a 60-day time frame. It still ends up being the same basic due date, but you got the information earlier. Now, just like in the past, if you need an extension, we can certainly work with you on that, but we just thought we'd start earlier to give providers more time to get going on things. So it's not a drop dead date. If you need a little bit more time, just ask the auditor. And I'll go with the webinar next. The webinar was 226 last year. It's going to be 210 this year, so a couple weeks earlier. And part of that's due to the fact that you have the letter earlier. That's still about a month after you got the letter, but gives you time to get started on it, get thinking about it, things like that. The other big thing, this is hopefully going to be a beneficial change to all parties. Up till this year, up till this next year, I should say, there was an instruction in the letter to hold off on submitting data until the assigned auditor reached out to you. The auditors generally didn't get assigned until closer to the end of February, early March. We have, some auditors have left or been promoted to other areas. We have newer auditors coming in. So we didn't assign them until we got the locked in list of auditors that were going to be working on the project. And the problem is, many providers have that information ready to go. They wanted to submit it. The way our portal works, you can't, unless you've already been working with an auditor, you can't send information through that secure portal. They have to open the door for you, so to speak, with an initiation email. That's just a security issue in it. And that was frustrating for both parties, both sides. So what we're changing this year is that on the letter that gets sent out, there's going to be an initial auditor assigned to you. It will, in many cases, not be the same one that's going to be the final auditor because, again, we don't have the final audit list until closer to that end of February, early March. But you're going to have a person you can send the information into. And there's a small group we're going to have handle this. They're going to reach out to you through secure file exchange, secure portal, and you can send it into them. And they're just going to get the documentation ready to go. Again, sometimes that might still be the same auditor that you work with at final, but if it's not, you'll be notified of who that auditor is. So we're going to use the contact information we have from the last S10 audit, the email addresses we were working with. So if something had changed, just let us know and we can update that log. So hopefully this will help both parties so we can get going on these and get everything ready, and there's just less frustration for all parties. The other thing I do want to mention about these new dates, they don't apply to every fiscal year because the last 2 fiscal years of that range, they might not even have the cost report submitted yet, especially if they had an extension. So the last 2, maybe even 3 fiscal year ends, they might be pushed forward a month just to give everybody a chance to get their cost report filed, all of that. And but again, other than that, you should be receiving those letters. They're already dated 1/9. We're going to have them ready to go at that point. And then on 1/9, they'll be sent hard copy like normal, but they'll also be emailed to whatever contact we have from the prior year. So as far as what is going on with the next year, what do we plan? We expect it to be the same data request. In other words, the basics of the letter, what we're actually requesting will be the same. We have the questionnaire that's going to be mostly the same. We'll have a few tweaks to it just to clean up, especially that line 25.01 issue. We'll have a little bit more clarity on some of those things. And then the template. This was the big thing we were working with to see what was something going to change. It sounds like there are not expected to be any changes, so we will use the same template. Now, you may recall last year there was the issue with the new T18 template came out, and CMS and their S10 contractor initially wanted us to use that new T18 template, but then we were able to work with them to basically get approval. Or I'm sorry, no. They initially wanted us to use the old template. The T18 template had to be submitted through the cost report anyways. They initially wanted us to use the old template because that matched the audit program that we had. But after we were able to work with them, a lot of discussion with the MACs, a lot of pushbacks from providers, they did agree to use the T18 template that you're already submitting with the kind of caveat or the statement that we need the transaction code. That's not on the T18 template. That was pretty much the biggest reason why they wanted us to use the old template, because our audit program, I can't go into great detail on what it says, but it requires us to use the transaction code to clean up the listing. And without it, well, I'll get into what the problem is if we don't have it. So this reason for the transaction code, the entire purpose for that is to help us to determine, was it really written off as charity care or bad debt, or was it something else that's not allowable, like a contractual adjustment, things like that. What the way they require us to do the audits is that they require us to go through kind of phase 1, which is cleaning the listing up, trying to identify those obvious things that should not be allowed. And then we can clean that listing, remove those, and then what's left, we'd have to go through the sampling and detailed testing for, depending on the scope. But the point is, if we don't have that transaction code, we can't do that cleanup that's required of us for the audit program. And if we can't do that cleanup, if we absolutely can't get the transaction code, then we run the risk of having to possibly expand the sample, but also have unnecessary statistical extrapolations. Because if those obvious errors couldn't be found up front, and then they're found during the sample, then all of a sudden that's going to be an extrapolation item. And nobody really likes the extrapolations. it's much cleaner to be able to identify those errors and clean them up without having to extrapolate anything. But there are obviously some things that can't be found just from the listing, and it requires detailed testing. So one of CMS's biggest statements, and when I say CMS, by the way, I'm rolling up, there's a contractor that works with them on some of these different things like S10. So I'm just generically using CMS to identify that. But the point is, they really want us to avoid extrapolations whenever possible. They'd rather us do other ways of reviewing that. But in the end, if we can't do that initial review, we have to extrapolate if we're doing a sample, statistically valid sample. So the point is, if we include the transaction code in that listing, then we can avoid all that mess. So that was the whole reason for the push last year. But we don't expect the template to change. We don't expect the audit program to change. So unless something surprising happens very last minute, I just don't expect it. Now moving on to one of the topics that's been really confusing this year. They added line 25.01. I mean, line 25 has always been a little bit confusing, but it was not used as commonly because it was limited to a certain situation. Line 25.01 is basically the same mechanism that's always been confusing, but it's used for many more situations. And what this boils down to is if you have uninsured patients, those amounts are just going to be charges, and they're subject to the cost to charge ratio. Generally, if you have insured patients, kind of the assumption is that that's of that claim was not covered. Maybe it was just due to some sort of limitation, exhausted benefits of some sort, where halfway through the claim they exhausted their benefits and the rest of the claim is not covered by insurance. For that non-covered portion, that's now a charge amount. There is no deductible or coinsurance for that piece. It's a charge, and it needs to be subject to the cost to charge ratio. Now, that has been a situation in the past. I mean, that's existed since the beginning. For line 25, if it was a Medicaid patient that exceeded their length of stay limit, so they exhausted their benefit, line 25 was used to report the non-covered charge amount. Now, the important thing to understand here is that that same amount that was in line 25 also needed to be part of what was in line 20, column 2. And of course, I'm talking S10 here, worksheet S10, line 20, column 2. And remember, I said earlier that column 2, well, I said insured, but that's column 2. Generally, that was deductible and coinsurance that was not reduced by the cost to charge ratio. But for any amount that's in line 20, column 2 that is truly a charge number, that needs to be reduced. The only way the system knows how much of line 20, column 2 is charge is it looks at line 25. That amount out of line 20, column 2 is reduced. So the same basic mechanism works for line 25.01, just for a different reason. It's a different non-coverage reason. And it's not a Medicaid length of stay. It's basically any other reason that part of that claim might not be covered. I shouldn't say part of the claim. Sometimes it's all of the claim. It could be that certain services weren't covered and the rest of the services were. It could be, again, an exhausted benefit situation. There are a variety of things. And we're going to dig into this in much more detail in February's webinar, where we'll cover this again, which, by the way, I guess we already talked about that webinar. So the old way of doing what's on line 25.01, the old way of doing it before they had this was just to split the claim. The non-covered portion of that claim just went into column 1 as uninsured, the charge is there, and then the covered portion went to column 2 as insured, and we're fine. But now they want us to use line 25.01 instead of splitting the claim. And there are a couple things with this that we found throughout the year. First of all, the amount, let's see, I have that on here. Yeah, the amount that's on line 25.01 or line 25 or the combination of the two, that should not be the exact same number reported on S10 line 20 column 2. That was absolutely not the intent. And that'd be very, very rare. I mean, that'd be unheard of to have all of your insured charges non-covered. I mean, every single insured charge you have for every single patient, that's extremely unlikely. So for that reason, S10 line 20 is generally expected to be quite a bit higher than the sum of 25 and 25.01. So just one more reminder though, any amount you've put in line 25.01 or 25, both of them basically, needs to be part of what's in line 20, but not all of, generally not all of. That'd be very unheard of. If you don't, then it's going to mess up the overall cost. And actually, if you do it that way, it's going to be to your detriment. It's going to reduce your allowable S10 cost. So that's one of the things we have to separately sample and test, or separately test, I should say. There are a variety of ways we test it. So yeah, we have that there. And again, we'll dig into that in much more detail in February again. Now, one of the other things we're trying to get CMS to do is clarify those instructions for both column 1 and column 2 as it relates to those partially non-covered situations, because they've got some really confusing verbiage there. They talk about charges or the portion of charges other than deductible, coinsurance, and copayment that represent the insured patient's liability for the hospital services. And that explains that, hey, they need to be included in line 25.01, even though they're already part of line 20, column 2. This charges or the portion of charges basically means all charges or just some of the charges. So our stance has been that if they're fully not covered for that stay, that doesn't on instructions. I don't think I have those here. It has some verbiage that almost kind of contradicts that, and it almost seems to say that if it's a fully non-covered charge, then maybe that needs to go in column 1. It's almost kind of conflating the terms uninsured versus non-covered. So we really need to ask CMS what do they intend, because it could be read two different ways. Our stance has been this way, but I could see another argument for it. So more to come on that next year. You know, we're already too late in the game this year anyways to do anything about it. The other confusing thing we want them to clarify is the template T18, the T18 template, column 6, it has this code. The insurance status, whether they're covered, non-covered, partially covered. So it's really confusing here as well. We've talked about and we've listed our stance on this, on what they might have intended, but it's definitely still ambiguous. And the fact that even our clarification is late in the game, you know, we talked about it last year, but you've already submitted your template by then. And again, there's still confusion even to this day. You've already submitted the second template, the second year's template. So the point is, the code itself, since it's so ambiguous, there's not a perfect right or wrong answer. What matters the most is that the auditor understands what you intended that code to be, so they know how to interpret it and they know how to interpret your listing. That's the biggest thing that matters, because again, what those patients are is going to drive how we review certain things. We're going to split them, sample them separately. So just communicate that intent with the auditor. In the meantime, we're going to try to work with CMS to show them why this is confusing and try to get them to clarify it a bit. It's not going to help this year unless you revise that entry in the template, but maybe at least it'll help for future years. So this year, of course, wraps up December 31st. The MACs, the auditors are all working on those to get them taken care of, generally a little bit before then. The only exception there is if we have an amended cost report that is just now filed, let's say right now, for example, and it has DISH. It didn't have DISH before, so we didn't do an audit, but now it has DISH. then of course there's no way we're going to get that done by December 31st. So in those cases, it extends a little bit into the next year. But and for that reason, if you are amending for DISH and you didn't have DISH before, we certainly recommend doing that as soon as possible so the audit process can start and the data will be used properly. We said we're expecting to start the next year's audits early February. And again, no change is expected from CMS for the program or template. Just a little bit of information on some of the resources we have for S10, and we'll have the next training in February that we'll put out there as well. So that's S10, just a little introduction to that. And then provider-based physicians, this is a topic we've covered a little bit in the past, and some of these things recycle every few webinars if something's come up or questions have been asked. The link we have here is to the website, and we have a couple of different articles out there. One's on time studies and documentation, and then the other's on some questions that have come up from cause mostly, but it could apply to others. It's for systems they might have for tracking their physician time in the various areas of the hospital, whether it's patient related, non-patient related. And, these provider-based on your payments. It might impact some pass-through payments if you have cost-based pass-throughs, but generally it won't have much of an impact, nowhere near the critical access hospital impact, because they're reimbursed on reasonable cost. But that being said, it can still be scoped for both because the underlying data is still important to CMS. They use all the cost report data to set DRG rates and other things, the weighting factors for the DRG weights. So they use that information. It's still important to everybody. Otherwise, if it wasn't important, acute cares would have like just a skeleton of the cost report they need to fill out. And of course, that's not the case. So the provider-based physicians are reported on worksheet A82. We have the various adjustments we'll talk about. The main concern that applies to both types of hospitals is how the costs are split between the provider or hospital, if you want to call it that, versus the professional or physician component. The reason this split is important is that this professional or physician component, those services are assumed to be paid fee schedule, and therefore we do not want the cost on the cost report. So that cost has to be carved out, along with potentially some other things. We'll talk about that in a bit. The other concern that only applies to the non-cause is the RCE limits. I have a small screenshot of worksheet 82. I wanted to get it all on one view instead of splitting it into two. So it's a little small there. But we're going to talk about two different things that have a similar mechanism, A82 and then A81, kind of a similar adjustment mechanism. The A82, you have an actual line number for A82 here to reference it. But this worksheet A line number basically says this is the actual cost center from worksheet A that all these things are listed on. So it knows where to make the adjustment back to on worksheet A. The cost center physician identifier, it used to be a physician name, but that's not allowable anymore. So it's just more of a generic identifier. So now we have total remuneration. This is the amount of the salary or compensation that for this particular physician or group that is already included on worksheet A. That's the total remuneration. And of course, we'd want to audit that. We might need to test that. Now, out of that, we have a professional and provider component. The professional component, again, the physician component, this portion, whatever is included here, is going to be dropped off of the cost report. It's going to fall into this adjustment at the end. The provider component, if it's a critical access hospital, then that part's going to be allowed. But if it's an acute care or other hospital, that provider component amount first has to be subject to that RCE limit here. And it applies to each type of physician. They each have a different RCE limit. Now, all these other columns relate to this RCE limit. They basically adjust it in certain ways. First of all, the physician provider component hours, that tells them how much of an FTE we're talking about here. But then we have all these other potential adjustments to that RCE limit before it's finally disallowed and rolled up into the overall adjustment. So that's what we have for A82. Now, the way we see that split between professional and provider component is first through the allocation agreement, which is worksheet S-2 part to be professional component. Now, there is one exception, and CMS has clarified this in the past. There's an exception in the policy manual about if you're a medical director, the medical director doesn't need to file that allocation agreement. But CMS has clarified this exception to be one medical director per provider. It's the overall medical director and not individual medical directors for each department. So anything like that. And then see down here, the other exception for that 100% disallowance, they're kind of odd exceptions because so here, if you're already allocating 100% to professional component, well, then there's really no need for an allocation agreement because that's what would have happened if you didn't have an allocation agreement. So it doesn't matter there. If it's 100% provider component. Now, what that means is you'd have to document that the hospital had no cost related, they didn't pay anything to the physician related to the provider component services, or I'm sorry, related to the professional component services. It was only provider component. And the reason for that is that the physician themselves is still billing for their professional services. They never reassigned billing rights to the hospital, and none of the hospital's payments are for those individual patient services. So if you can document that and 100% of the costs are provider component, then there's also no need for the allocation agreement for that physician. A couple of the other things is that the allocation agreement itself must be contemporaneously signed, first of all, and that basically means you can't have it signed when we're about to do the audit. It has to be right around the end of the year. It might be a month, might even be 2 months into the next year, but anything past that starts to get non-contemporaneous. CMS is not looking for exact, like absolutely on the last day of the year, but it has to be reasonable. The thought is, if you're too far out, would those parties really remember the information about what happened that clearly? The further you go out, the less clear memory you have on that type of allocation. So that's why CMS stresses that. The other thing is that it does have to be signed not just by any, like an executive, for example. It has to be signed by either the physician themselves or potentially the director of the department because they're pretty close to that physician. It can't really be further away than that. And they have hit us and probably other MACs on these simple issues in the past, that we've allowed something that we shouldn't have allowed. So that's something we've stressed quite a bit over the 5, 6, 7 years. It's been a while. The other thing about this is that the allocation agreement itself is not the end all of it. That allocation agreement requires some sort of supporting document. Often it's time studies. But I just mentioned that article about the badges, the systems that a lot of CAWs have, and I imagine other facilities have as well. And it keeps a pretty good record of ongoing time reports. Or you can have other ongoing time reports. Any of those would be fine. We just need to see the record of time and how it's split, how it's classified between the activities. And by the way, back to that, I didn't go into much detail about those systems. If you do have one of those systems and you're curious about the allowability of it, the response there is that in general, there's no ban on it. It's not allowable. It's allowable as long as you've set it up properly, you have all the classifications working, and the documentation that comes out of it is auditable. That's the biggest thing. So it's a good system in general if it's used right. So there's nothing really wrong with it inherently. In fact, I'd say the other. I'd say it might be a good system. So the time, oh, and back to the questions. I see we have a question here for the total remuneration. Yes, you're exactly correct. It would be the salary and any of the benefit costs without the taxes and workers' comp. Yep. So that's kind of why they use remuneration as a term instead of just salary. So it does include those. Good question there. And the time studies. So this is something I wanted to stress because there are two different policies for time studies. The main one you might be familiar with, it's for non-physicians. It's section 2313.2. So it's in chapter 23 of PRM 1, Pub 15.1. It's called special applications. We're actually going to talk about this later when we get to organ acquisition. This is a very stringent set of time study criteria, but there's actually a separate one for physicians. And what it really says, and it's 2182.3, so it's in a different chapter. It's in 21 instead of 23. And what it says is where providers decide to employ time study techniques to substantiate the allocation of the physician's time to services, the provider may choose to employ the methodology described in 2313. In other words, you may, if you want to use those more stringent requirements of 2313 just to be standardized, certainly you can, but the provider may not be required by the servicing intermediary to utilize that specific methodology. So you have the option to opt out of it for a physician. Non-physicians have to follow it, but physicians do not. The general consensus, and we brought this up with other MACs at one point, it's been a long time, and it seems like many of them are on that same 2 weeks per quarter. I don't know that that's necessarily true anymore. Things might have changed. I can't speak for other MACs, but at one point this was pretty standard, and this is what we are accepting, 2 weeks per quarter. The thing is, since you're not bound to those specific stringent criteria of 2313, there's nothing saying you need a pre-approval of what weeks you've selected or pre-approval for any changes, as long as it follows, again, the 2 weeks per quarter, it's split properly, it has all the good documentation. You can send in a pre-approval if you want, if you just want to make sure things are good before you go through the process. But again, it's not required like it is for the other time studies. For example, organ acquisition, a lot of other things that are non-physicians. And what I mean by that is out of organ acquisition. Of course, you're going to have some physicians that would still have their regular time studies, but you're going to have a lot of non-physician staff as well that have to use those other stringent time studies. So we'll get into that a little bit more later. A couple of other quick little issues with provider-based physicians. The confusion with availability versus on-call. They're in two separate policies and regulations. They're two separate things. They have different requirements. They apply to different professionals. CMS in the past, and it's been maybe 7 years. 5 years have flown by pretty quickly. I think it's been 7 years. At one point, they talked about wanting to try to streamline and merge some of those requirements to make them more consistent. I haven't heard much since then and seen anything on it. We're going to still work with them and see if that's still something they'll talk about, something they're thinking about in our next meeting that we have with Max and CMS. But for now, they're separate. That's the point. So it's important to know what each one is and what's the requirement for it. Availability, when that term is used, it means on-site or just waiting to be needed for a service. But the point is they're on-site. Now, the confusion here, these terms are often used interchangeably, sometimes even with standby. That's thrown in here as well sometimes. But availability, and sometimes they even call them call rooms, which confuses it more. I mean, that's a standard term. I don't know if there's other terms used, but the physician's there. and they're just, again, waiting until a department needs them, the ER department, whatever. So the regulation and policy are listed here. This availability applies for acute or critical access hospital, but it's limited to just physicians. The on-call allows mid-level practitioners, but the availability currently does not. Now, one of the more contentious pieces of that policy, even though it's clear in the policy, it's still been the subject of appeals. And it's the requirement to have explored available alternatives before you started paying for this availability call or availability time. This is, again, it's been in appeals, and I wouldn't be surprised if this has changed. I can't speak for CMS, but this is just one of those things that's kind of up in the air at this point. On call is off site, so a little more confusion there, but that's when you're physically not there, the physician's physically not there, but they're close enough to arrive generally within 30 minutes. Certain areas have 60 minutes as their time frame. It's a completely different manual. It's one of the internet-only manuals, the Pub 100-04 Claims Processing Manual, Chapter 3, Section 30.1.3. And this one's only currently for critical access hospitals. Again, who knows how that might change in the future. This one does add in the mid-level practitioners. I just left in this piece accidentally. It does allow mid-level practitioners. So ignore this extra piece. And again, that's just a little bit of information on that. We do have some articles on that, and some of these things I'll be putting a YouTube video on at some point in the future. This isn't one that's been a big hot topic, but it'll be up there. And let me check and see if there are any questions on that topic. Okay. So let's move on to the topic of home office and related parties. Is that if you have a provider that's related either through control or ownership with another party, and that party provides a service to the provider, to the hospital, there's a concern about the allowability of that cost. What amount should be allowable? First of all, just to be frank, there's always the concern of manipulation. There's the concern of error, concern of overstatement. But the point of this principle initially was to avoid the payment of a profit factor to the provider. So even if we're not talking manipulation per se, we're just saying that that related party, they might be charging an amount that has a profit built in, but that profit is always scrutinized with related parties because there's no clean way in many cases to see if it's reasonable. If it's a purchase from some other non-related party, you have a reasonability assumption. There's no incentive for that other party to artificially inflate the price. There is the incentive with a related party. So that's the point there. CMS wants to make sure that profit is not flowing through to the provider for reimbursement. And again, anytime you don't have arm's length bargaining, there's just the question of reasonability. Now, we're not going to get into the details of common ownership or control. That's a separate topic altogether, what constitutes that. But for related parties, we tend to focus on the home office, and we largely will today. But there are also other related parties that are not a home office. They're just providing a supply. They're not providing overall management support. The home office has its own documentation. It's the cost statement. It's now Form 287-22. Other related parties, it's going to be up in the air what type of documentation you see. When I say documentation, we're talking about what the underlying cost is. You can easily see what the charge amount was, what was charged to the provider. An invoice would do that, but we need to know what the underlying cost to that related party was, because that amount is going to be allowable, not just the charge. Worksheet A81 handles all of these related party adjustments, whether it's a home office or not. Now here I have just a quick example of A81. Just like A82, it has these worksheet A line numbers basically telling us where on worksheet A was this cost already reported and where is the adjustment going to go to. So you see all these normal cost centers flowing through. Notice that some of them are duplicated because there might be more than one cost related to it. It might be more than one party, or it might just be more than one type of cost, and they wanted to separate that out, and that's perfectly fine. There's a free text field to explain what that is, but then we have the kind of the important part here, the development of the adjustment. So in my mind, column 4 and 5 are kind of flipped around. It would seem to make more sense to have what is already reported first, but it's second here. They have it in column 5. So this amount, what it represents is, for this particular type of cost we're talking about that's on line 23.01, how much was already reported in worksheet A column 5. So this 1,530,000 is part of what's on line 23.01. There's probably plenty of other non-related party things, but this is the amount of that that's a related party cost that's been reported. And it's on their working trial balance. I'll get to that in a bit. Column 4 represents what the underlying cost of that service was. Now, this particular one's quite a bit of a drop. I don't have any details. I just pulled a generic cost report up, or just a random cost report, I should say. But this creates a difference. They're saying, hey, they've already reported about 1.5 million of this cost, so they maybe were charged that amount in a simple situation. But when we look at the related party, the underlying cost was only 149,000. So we're going to have to adjust out that extra 1.3 million. And again, there might have been a variety of reasons for this. There's nothing necessarily suspect about this. Again, plenty of reasons it could have happened. Some of them are less negative, less of a different amount. And some of them go into situations where, hey, they didn't even report anything on column 5 yet, probably because they did not even incur that cost yet, or they never incurred it. There was no bill sent on that issue, so there's no cost on the working trial balance yet, but here's the amount that should be allowed. We have the home office cost statement, and this is the amount that was properly allocated to this component provider. So that's a positive adjustment. Now, the thing about this, I can make this statement in general about a lot of things. Some of the changes to the desk reviews that CMS have given us. One of the things we're focusing on across a lot of areas, because CMS requires it now, is working trial balance reconciliation. And what I mean by that is anything on the cost report that has an amount that's supposed to be able to be tied to the working trial balance, there's a good chance we're going to have to do that, depending on the scope. This is one of them right here. Any of these amounts that are worksheet A column 5, we might have to test this against the working trial balance and dig into the detail to find that related party cost and make sure that this was truly the amount that was already reported there. It makes it a little bit messy, and I guess I'm getting to that in the next slide, because this column 5 is after reclassifications. Your working trial balance is obviously before any reclassifications took place. That's basically column 1 and 2 of worksheet A. The reclassifications, the whole purpose of a reclass is that the way you reported things for GAAP, for financial accounting on your working trial balance, don't always match up with the way CMS requires things to be classified. So the reclass moves that cost out of one cost center and into another. So trying to tie that back to the working trial balance accounts can get a little bit messy because of that. Again, if we have to scope it, then we'd have to go through that detail. But the point is, if you see requests from auditors now looking for working trial balance support when you might not have seen it in the past, that's the reason. Let's see. And then for the allowable cost, again, if it's a home office, that's going to be the documentation. We're going to have to go through and figure out how it's been allocated each component. That home office might be audited itself. And then that's where these amounts come from. But if it's another related party, again, there's a lot of documentation that might support this. That's A81 Part A. Part B gives us the detail of who these related parties are and are they owned in part by the provider or vice versa. They don't have to be owned. Again, it could be control, but there's just information on it. The problem with this form of worksheet A81 is that there's just not a good link between what these costs were and which of these parties it relates to. In the past, we've even had situations where a provider might have merged multiple different types of costs from multiple different parties, but they all impacted line 50, for example, so they merged them all onto the same line. And as you can imagine, that makes it really messy to find documentation for this 282,000. So this was again, actually, I think it was right at 5 years ago, it was 2020, we suggested to CMS that this be somehow linked to this more clearly, some indicator on A81 to show which of those parties this cost was from, and more of a requirement that they be separated out by party, even if they're both impacting the same line. They said they're going to be doing that in the next transmittal for the hospital cost report. And the good news is they've already done it for the home office. They renamed worksheet A81 for the home office, and they basically have already implemented that suggestion we had. So we expect it to look the same when they do it for the hospital. Now, I'll get to that in a second. I'll show you what that looks like. So here's worksheet A, just as an example. And we said line 23.01 back here for their other med ed had $1,530,000 of related party costs that was already included on 23.01. Here on 23.01, their column 5 is 1,573,000, which is 33,000 more than the related party cost. So that means there are $33,000 of cost in this cost center that were not a related party type thing. Nothing wrong with that. Usually there's more of a difference between the numbers, but things. This reference is how much has already been reported right here in whichever cost center it relates to. And then the adjustment will flow with any other adjustment into column 6. So yeah, we have a good question there. For hospital A provides laundry services to hospital B. So assuming they're two related parties, then part B, how would part B be filled out? So you would actually put in that hospital because it is still a related organization. It's not a home office, but you'd want to fill out that related party and just explain like laundry services, for example. And then of course on this cost, on this part A, you'd have the cost that was basically, if there was a charge and it's the amount that hospital B incurred through that charge, that would be in column 5. But then hospital A would have to identify what their underlying cost of providing those services were without any sort of markup. And that's the amount that would be right here. So good questions there. Not necessarily. So in this case it was, and whatever ownership percentage you have. Now the thing is with related party, it does have to be significant controller ownership. So if we're talking like 5% ownership, it's probably not going to meet that threshold. 20% just from GAAP accounting in general, that's kind of where you start to get significant influence. So, but again, that's an open question. You'd have to look at all the details of that case to see just how much control did they have. But it definitely doesn't need to be 100%. It does not need to be 100%. So good question there. The way the home office will do it is they'll have 2 lines on all their worksheets or their schedules for each component provider. One for the first a year that's impacted, one for the second year. And that makes it really nice and clean when we're actually trying to gather the data from the home office. We know which of the years to pull it into. If they don't have that clear split, then we have to use a simple proration, generally day-to-day proration. So just split it by the number of days that were impacted by that home office cost reporting period. And this should answer your question about can the provider have more than one home office? So yes, there certainly can be. In fact, there definitely could be more than one related party in general. You can get supplies from many parties that you're related to, but there could be a situation where there's a home office. There might even be a regional office providing some services, and we'll get into that part in a little bit. I suppose, and definitely if you changed throughout the year and you didn't have a split cost report for some reason, I mean, there could be more than one home office there as well. It's all about, can you support what services they were providing? And if it gets into the detail, can you support that they weren't duplicative? They were both reasonable. You needed all those different services. So that gets into the question of reasonability. That's a completely separate, more in-depth topic. But technically, yes, you can. And again, we talked about that linkage between the two parts of A81 that we'll see here in just a bit. And that's actually right here. So the home office, the new form set, they revised. This is the most significant revision to the home office cost statement they've had in a very long time. They renamed a lot of the schedules, and a lot of them made more sense now. They actually call the home office related party worksheet A81 now, just to match the providers. So you know exactly where to go for it. Now on this A81, they have a part 1 and a part 2 instead of part A and part B like the provider. I don't know why they were inconsistent there, but it's the same basic thing. Part 1, again, you have your worksheet, your schedule A line number, where this is being adjusted to. You have your description of the related party item. And here's the new piece that's so important. This is what we were kind of recommending. This is the way CMS chose to implement it. We gave them a couple options. They went this route. The other option, by the way, was to essentially integrate Part B into Part 1, extra columns at the end, but then you'd be repeating a lot of the things over and over and over. So instead of doing that, they linked Part 1 to Part 2 with a line number reference. And the rest of it's still the same, the whole adjustment itself. But again, this column here, it'll tell us where on part 2 is the related party that provided this service found. So here's part 2 now. It's a little more cleaned up. And again, it tells, what type of description do they have? What are they? The name of the related party. If there's ownership, what percentage ownership? And then the type of business. So this is all the detail about the related parties. Oh, and I guess here they have individual versus organization. That's the difference. I don't really know why they felt the need to separate that, but in any case, so this here tells you, again, for each of those costs, here's where that related party was. And for this reason, you can no longer merge two separate costs from two separate related parties in the same line, because this only allows for one entry, one reference to part 2. So that really cleans it up quite a bit. Now, I just briefly want to go through the allocations on the related party or the home office cost statement. This is also something that we can dig into in much more detail. And it's something that I'll probably at some point, now that we have this new form set and we've been using it for a while, I'll probably create a YouTube video for this with an example, a generic example. But they've renamed these as well. B part 1 and B-1 are direct. I hate the word allocation there, but they're calling it direct allocation of capital and non-capital related costs, respectively. The reason I say I hate that word there is that direct is actually assignment, which means you know where it goes. There's no real question. There's no spreading it. You know where it goes. You have documentation to prove it. Allocation just connotates more of a little bit less certainty, and you're just trying to spread it out using some sort of proxy, like a statistic. So that's what allocation to me is. That's the connotation of it. We'll get into those ones later on. This used to be called Schedule E, and it is definitely the preferred method. It's more accurate when you have the documentation to do it, which not everything works for it. In a perfect world, you'd be able to, but right now that's just generally not possible. If you do use direct assignment, we need that auditable documentation. For example, electricity, you might have metering, uh, other services, you might be able to show how many hours of service of this specialized service were provided to that provider. So if it's a nice clean cut thing like that, then you can use direct assignment. The next best thing is functional allocation. This one also has capital versus non-capital, but it also has a separate -1 type worksheet. Just like worksheet B and B-1 on the hospital cost report reflects overhead cost and then the statistic to allocate overhead cost. These are the same things, these -1s, the statistics that are functionally related to how that cost is being allocated. And that's a key word there, functional. We can't just use any random statistic. It has to be something that has a strong correlation to show how much of that particular service was really used by that component versus another component provider, and therefore how much cost should be allocated. A couple of things that come up even recently in reopenings, we've had this. Total costs are virtually never. I mean, I can't see a situation where they would be allowed as a functional allocation cost or statistic. They are actually the pooled allocation statistic. Total revenues, it's one of those virtually never type things. There could be situations where revenue might really show how much of that particular service was driven and needs to be allocated to each of the different components. But again, generally total revenues doesn't really work. It shows the size of the providers, but that might not mean they got that much of that particular service. So it's all about how strong that relationship is with that statistic. This is the old F and F-1 on the worksheet or on the old form set. A couple of things about the instructions, cost reporting instructions, and specifically with changes. Just like any B-1 statistic, if you need to change that specifics here, you have to get it approved. Let's put it that way. So 287.22, when CMS just recently updated this, they referenced kind of the wrong section, wrong chapter for the changes. They referenced the hospital section, 15.1, chapter 23, section 2313. That's what you use for changing statistics for your other provider types, your hospitals. The request here is that it must be approved 90 days prior to the end of the cost reporting period. So that gives you most of the way through, but you might want to do it even earlier in case that statistic is deemed not allowable. That puts you in a bad position. That's for hospitals and such. The reference to home office statistic changes is actually a different chapter, 2150.3, and the request there has to be made no later than 120 days after the beginning of the cost reporting period, cost statement period. So it doesn't quite line up. And again, there's that section down here. So we'll point that out, see if they can relink that to the proper change. But just wanted to point that out. And again, the statistic, it's the same request. You send it to the same audit.advisement email address, and we'll go through that. We just need to see an explanation, maybe even documentation for why that statistic makes sense to allocate that type of cost. So now let's move. Oh, by the way, I do want to go back here for a second before we get into the pooled. Notice that each of these worksheets, B actually has part 1, 2, and 3 as well. And then C has part 1, 2, and 3. We'll see what that means in just a bit. E has the exact same thing. And I'm actually going to bring up, That's the hospital. Need to bring up the home office here. I'm going to show you this. It makes me get that again. I still have the hospital opened up. I'll open the home office now. There we go. Close that out. So I wanted to show you, let's just go to B. And again, this is just a random home office. That number is not even the real one. Not that it would matter. It's public information anyways, but it's not the real one. So B part 1, 2, and 3. If we take a look here, B part 1 and all the part 1s are healthcare provider components. So the actual providers. These are the ones that are going to have separate cost reports altogether. B part 2 is for any non-healthcare component you might have. I've seen some, hotels, some other types of entities that they operate. Everything, not just providers. So we want to make sure that cost gets allocated properly to everything. Part 3 is the regional or divisional components, which are basically like regional offices. You might have a central home office, and if it's a big chain, you might have regional offices underneath of that help support certain providers. We'll see that in a little bit. But CMS, I really like this change that CMS made because they're really clearly drawing out the need to allocate these separately, especially for these regional offices. And I'll get back into that in a little bit. But you'll see this exact same thing on all the other form schedules related to this. So that's all I wanted to bring that up. Oh, I do want to, I guess, bring it up for this one too. Let me get to E here. So E is the pooled allocation. It's the last resort when you have no better way of assigning or allocating this cost. We're going to use a options there. So there are two parts to this. The statistic is actually built into each of these parts. There's a little drop down. You don't need a statistic for multiple cost centers like you did for the functional. So this -1 is not a statistic. It's a second level of allocation. The first level of allocation is to the groups themselves. So you're allocating the total costs to your group of healthcare provider components, your group of non-healthcare components, and your group of regional offices. Now, the regional offices are later going to allocate costs to their own components on a different, basically a home office cost statement, often called a regional office cost statement at that point. The non-healthcare components, again, once that cost is there, that really doesn't go anywhere. We're not reimbursing them for anything. The healthcare provider components, they're the ones that we need that cost for. So CMS has done this first step of allocation to get the costs that only relate to healthcare provider components first, and then E-1 parts 1 through 3 takes that group cost and allocates it to those individual components. So let me see here. See what we have on that. Yeah, there we go. I just wanted to bring this over. I made it generic here. Again, not that it really matters, but for Schedule E, here you see some cost between healthcare, non-healthcare. Apparently they didn't have any regional offices. That's perfectly fine. Here's that statistic. They have total costs, or if you can support some other pooled cost, that might be allowed too. Total cost is by far the most commonly used. And this just gives us the cost related to, again, the healthcare components. That's what we're mainly concerned with. Now, E-1 takes that cost and allocates it out to each of its individual components. These would generally be providers. They'd have their own individual provider number. Now, this is what these costs right here are what we'd be pulling for our A81 on the hospital cost report. So that's how this schedule works. And again, the biggest thing here is that regional office is separate, because what CMS has said in the past and what we've brought up, what we've found in the past, is that we had some chains that were reporting their regional offices right here along with the healthcare providers, which was never allowed, but now is very clearly not allowed. They've very clearly labeled everything. They're not supposed to be an individual component and just merge together. This is for the healthcare providers that this overall home office provides service to. And then what you're going to have is any of the costs that went to the regional offices, they're each going to fill out their own regional office cost statement, and their cost, including what the home office allocated to that regional office and whatever direct costs the regional office had themselves, that's going to be allocated to only its components, only the regional office's components. So CMS has really done a good job of cleaning that schedule up to show that that's how it's supposed to be. So here's a very simplified illustration of it. You have this overall central home office, and they might be providing some services directly to the healthcare components. They might also be providing some overall administrative services to the regional offices. And then again, at the regional office level, they're going to have any cost that was allocated to them, plus their own direct costs, which I'm sure they'll have plenty of. And then they only allocate it to their specific healthcare components. So at the provider level, the hospital level, they might be getting some allocations from the home office as well as from their regional office. And that's the linkage that's supposed to exist. So there is some information on home offices. Again, I have one YouTube video already, but now that we have a new form set, we'll be putting another one out with some more information. A couple other quick links. There is establishing a new home office. If you're in that situation and you need the details, there's the link to find the application, just necessary documentation and related party costs from another provider, like an acute that's providing managerial service to a CAW. That article goes through that linkage. I also included HFS's training document on the new 28722 form set. So let's see here. Some of these things, we're a little bit past the halfway point time-wise, but right at the halfway point PowerPoint-wise. So some of these things I'm going to have to shorten up a bit. For capital-related costs, this is just a little bit of detail. If you are planning to relife the asset, if you have reason to believe, a good documentation, good explanation to believe that that asset's life, maybe it's no longer going to last as long as you initially expected due to technological obsolescence or excessive wear and tear early on, more than expected. If you have one of those reasons, you can request a change in that life. It's somewhat of a rare thing, and you have to have really good, strong documentation for. But if you can prove it, then we can allow a shortened life and basically now an accelerated depreciation schedule. The reason it's so scrutinized is that the obvious result is that you're going to get more cost up front. If you're a critical access hospital, that's more reimbursement up front. So that's only allowed when there's a very good justification for relifing the asset. The fact that you're planning to terminate in a couple of years, or even the fact that you're planning just to buy a new asset in the next couple of years, in and of itself is not good enough explanation. You have to show that that asset truly would not last as long as expected for anybody, not just you, but for anybody. These are the ones where I probably won't go into as much detail as I did yesterday, but I'll still go into some important detail. These are capital-related costs items, and these relate to how we count the square footage. Both of these topics I'll talk about relate to how and when we count square footage, because that's what's generally used to allocate capital costs between the cost centers. So this first one is called idle space, and we want to know, is this space really being used for patient care? And if not, what's the situation? That doesn't necessarily mean it's not allowed at all, that year, but we definitely have to dig into detail if it's scoped. It depends on why it's idle and how long it's idle for. Every facility, by the way, is expected at some point to have some idle space. There might be a room that's taken out of service for a little bit, it's just not being used, period. It could be used, but it's not being used. There might be a wing that has to be temporarily shut down for renovation. Those are temporary type things that don't necessarily mean that cost is no longer allowable, or that square footage and therefore the cost. But we need to know the reason. So we're going to define these terms, and then the next slide gives the explanation on whether it's allowed and what the detail is. If it's shell space, this is generally new space that has not been fully completed. It's not ready to be used. It's not doesn't have the equipment. So again, it's shell space. We'll talk about that in a bit. New idle space is very similar to shell space, except it has been fully completed and equipped. It's all finished. It just hasn't yet been put into service. So I'll talk about this cost in a bit, but generally with depreciation, when you capitalize an asset, you don't start depreciating it until you put it into service. So that's going to be the factor at this point. It's an asset until it's being used into service. And shell space is kind of just a little bit before that. It's not even fully completed yet. Now we get into temporary idle space. This has been used. It could be used. It's just right now your volume of business dropped a bit and you don't need to use this right now. It could change in a few months, might be next year. Temporary idle space. Permanent idle space is where it's been permanently taken out of service. Now the word permanent, I mean that kind of sounds, it kind of implies forever, never again to be used. That's not the situation here. It's just much longer than temporary. Let's put it that way. So if you have a building or a portion of a building that's been taken out of service, either never to be used again or just it's been out of service for quite a long time, and there's no intent to use this space in the future. And often these spaces, like a room, for example, might be even stripped of their ability to be used in the near future. We see this with IME and dish, where we're bed counting, and if the bed has truly been taken out of service, then we need documentation to show that it really can't be used quickly. A lot of times that's simply, hey, the gas hookup's been removed. There's no way that can be used quickly for its intended purpose. That would be one example of how it could have been stripped of its ability for immediate use. But if this is permanently idle, it's not being used for patient care, unless you have evidence to show that there is some other use, then it's not really considered permanent. It's not idle at that point if it's being used for something patient care related. So we already talked about the shell and the new idle space. It's just a matter of timing when they're going to be used for patient care. Temporary idle space, it's fine as long as it's been used. It could be used quickly. It's just, temporarily not being used. There's nothing wrong with that. It's an expected amount to an extent. Permanent idle space, not being used for patient care, no sign of when it might be used for patient care. The cost itself is not allowable, and it has to be reclassed to a non-reimbursable cost center. I shouldn't say reclassed. It has to be adjusted. Now that's the wrong word to use as well. The square footage and any other statistic has to be set up in a non-reimbursable cost center. That's kind of the backdoor way that the cost is quote unquote reclassed. That's how it makes its way down. It gets allocated to that non-reimbursable cost center. So when we're auditing square footage, we'd look at that. So we have a couple questions here. GME. So I don't know that we have, like, for YouTube videos, we don't have any IME or GME training at this point, but that's certainly something a little bit. It's definitely a bigger topic, so it would be broken up into quite a bit of detail. But yeah, anytime we do put that out there. In fact, if you go to our, I'll mention this at the end. We have a YouTube. Basically, it's a landing page, or it's the channel, I guess. It's the main page of the channel, and it'll list all the different videos we have. So that'd be one way to find kind of the and we asked them to approve it. And I do have to look back because I think the last time we asked for that, I think they actually gave us approval for that one, which was a few years back. But I believe they also gave us kind of an implied approval for as soon as a new one's published, you can use it. So they're not going to go through year by year anymore. But it's been a while. I'm pretty sure on that point, but let me just double check to be certain. And if that's the case, I'll send that out. And that's also a good thing to put on the website. So I'll send that on the email that I send out to everybody. I'll send the answer to that one because I'm pretty sure on it, but I want to be certain. So let's see. The other big one here is gross versus net. Now, this is for how you count square footage. Now, of course, this stuff, anything capital related, anything cost related, definitely impacts a CAW more than any other hospital. But again, the underlying data is important. So gross, and this information, by the way, comes from a very old AHA cost manual. It really hasn't been addressed since then, but it does a great job of going into the accounting details of it. So these are two methods you can use to determine how you count square footage. The gross method, it says it measures from the outside walls to the center of nearby corridors or hallways. So if that particular room, that department, they get half of their hallway, the square footage for their hallway, and the other room across the hall gets the other half. So the point about gross is that you're counting all square footage, and then it's going somewhere. Every single square foot in that hospital is going somewhere. If it's non-productive space that can't be easily tied to like a normal cost center, a revenue-producing cost center, it just gets included in the operation of plant cost center, a general service cost center, which of course would be allocated separately. You could argue perhaps that maybe A&G might make more sense than operation of plant, either one, but the point is it's not going to a normal revenue producing cost center. Now the outside of the walls, that only works if you're working from blueprints or floor plan. You're not going to physically measure, you can't go from inside to outside of the wall. I suppose you could just measure generally how thick the wall was, but that's not the intent. If you're using a tape measurement for this, you can just use the inside of the wall. That extra square footage is not going to matter. It's just going to reallocate everything. So these are quotes, by the way, from that manual. We also have a little bit more information from an appeal that we had with the PRB way back in 2005. Common space is assigned to the physically adjacent cost centers, like the hallways. Now, key thing is where possible. It has to be related or close to a cost center, or otherwise it goes to plan operations if there's nothing else to identify. But the net method, which is the other one, the whole net means something's been subtracted, and here any of that common space is subtracted. Hallways, waiting rooms, things like that are subtracted. And that means that the total square footage number is less, and obviously every individual cost center would have less as well. They don't count their hallways anymore. And it might change the allocation a little bit, but the point is it's an easier way of counting. You have both methods to use. The goal is to remain consistent. So that AHA manual, back to that, when they define that method, they're saying only the usable space is measured. So none of that, and by usable, we mean usable by that department and that department only. Any corridor within the department, and this is the key thing. In other words, it's only used by that department. It's not truly common space. That's considered usable space that would be counted because it's very clear that it can only go to this department. No other people are walking through it. They're trying to go other places. If there's a general traffic area that any type of patient or any type of professional can go through, elevators, lobbies, waiting rooms, those are eliminated. That's the whole purpose of the net method. Now, I'm not going to go into this argument, but it's function over location. This is basically the explanation for why waiting rooms in general, no matter where they're located, they functionally are a common area and they're excluded. Same with the hallways, with the few exceptions of those that are closed into that department. They can only be used by that department. That's the only real exception to the hallways. One last thing on the capital related costs, and this is more for the, I mean, this is for the provider themselves, the hospital, how they're reporting it on B-1. Generally with movable equipment and buildings and fixtures, you might use square footage, but movable equipment could also use dollar value. The question here is, what really does dollar value mean? It can mean a lot of things. What does CMS intend it to mean? What do we need it to mean? The important thing here I'll mention is that it does not mean dollar value of depreciation, because you're trying to allocate depreciation. You can't use depreciation as the depreciation statistic. You can't use the cost that you're trying to allocate as the driver by which you allocate it. That'd be direct assignment by definition. It's not a statistic. So it's definitely not that, but there are other two values it could be. Initially, the dollar of investment, or you could argue it might be your net book value at this time for those assets. If you go to section 2338, that's really the only clean reference I've seen that tells you much about dollar value. They say dollar value of equipment, but down here in their example, they go a little bit more into detail when they're calculating that rate per, instead of square footage, it's per dollar value of investment in movable equipment. So dollar of investment, that can really only mean the original historical cost that you invested. Now, that's not saying we're only going to allow this. At net book value, there's a good, strong argument for that as well. But either of these two could be allowed if you use dollar value. Just be consistent or constant, and there's the example for that. This one, I think I'm just going to skip. We are going a little bit longer on some of those earlier topics than I expected, although I did expand the PowerPoint a bit. And, you know, I'm just going to very briefly go through this. And I do have, we did this in a prior webinar. We went into more detail on these, and I'm going to be putting a website article and a YouTube on this as well. This is something we really haven't had in a YouTube video. Sales and donations are not allowed. They haven't been allowed for decades. So the loss on the sale or donation of an asset, in other words, the undepreciated net book value that you're giving up because you're no longer depreciating it under the program, that's not an allowable loss. You can't take a last minute hit for that amount and get reimbursed for it. Here's the policy manual for that. There are three that could be allowed: demolition, abandonment, and involuntary conversion or casualty loss, like a fire, flood, things like that. Demolition, you can be breaking that into two different things: the true cost of the demolition, but then also that loss of remaining net book value that you can no longer depreciate. There's a lot of detail in the manual about when this is allowed, specifically when this loss is allowed, loss on remaining net book value. And you need to know how far through the depreciation schedule was it, what percentage is it depreciated, was it replaced or not, and if it was not replaced, was that demolition and non-replacement approved by the regional office or intermediary? So again, there's a lot of detail. There's, I think, 4 different scenarios that tell you if it's allowed, and if so, how you allow it. But again, that's far outside of the time I have for this particular topic. It is in one of our earlier webinars, I think it was last year, and we'll put a webinar or a YouTube video out on just these losses. It's a good topic. Abandonment, really quickly. Abandonment is not, you can't donate an asset and say you've abandoned it because you exercise your control to determine who now owns it. Abandonment, you're completely giving up ownership rights, and generally that means it escheats to the state. The state takes over ownership of it. It's not the same as a donation to the state. So it has to be truly an abandonment. There's a little bit of detail that goes into that to determine, yes, it was fully an abandonment. And then again, involuntary conversion, casualty loss, there's more detail there as well. Time studies, we're talking non-physician now. And I talk organ acquisition, although it applies to many areas outside of organ acquisition, but this tends to be one of the more complex ones. And again, we need some sort of reference for how those costs are split, how the salaries are split. It could be direct costing or time studies. But also we need to allocate between the different types of organs those individuals might have been working on. Now, if it's salary, we still need that time study, generally speaking, or direct costing. But if it's a non-salary cost you're trying to allocate, then you can allocate it by organ count. And there are a variety of different things that would be there. So just split it out pro rata based on the number of organs that type of cost covered. These are very stringent. They're, in my mind, overly stringent. I'm not sure why there was such a need to make these so stringent, but it's extremely clear in the manual, and we have had findings on those as well when we don't follow that manual word for word. It'd be great if CMS decides to relax those in the future. If you do for a non-physician, you have to follow all these criteria. First of all, it has to be submitted for pre-approval 90 days prior, and again, I shouldn't say pre-approval, approval prior to the end, 90 days prior to the end of the cost reporting period. And then we'll respond within 60 days. It has to be 1 week per month, so 12 weeks generally. You can define the week, but it has to be a full week. It could be either a Monday to Friday week, Monday to Saturday, Sunday to Saturday. You define how you're tracking those weeks, and that has to be in your request. Now, here's where it starts to get really into detail. The weeks selected must be equally distributed among the months. So, for example, on average, 3 of the months have to be using the first week, 3 have to be using the second week, 3 have to be using the third, so on. Here's this, again, it just digs into more interesting detail. No 2 consecutive months can use the same week of the study. I'm not sure what the reason was there, but for April, you can't, if you use the second week in April, you can't also use the second week in March or May. So you have to use first, third, or fourth in March and then something else in May. This is a big requirement, just like the allocation agreement. The time study must be contemporaneous. You can't try to do this 9 months, 10 months after the fact. But the other thing this means is that you can't use one cost reporting period's time study to allocate costs for a different one. You can't just do a time study and let it work for 5 years. That's not allowable. It has to be year by year. And it also has to be provider by provider. If you're a chain, you can't use provider A's time study to allocate costs for B, C, D, and E. So when you submit the request, again, you have to define that week and use that definition consistently. We're not saying you can never change it, but you can't just go back and forth year to year. You have to put that change in the justification in the request. The ordinality that you're using, the first, second, third, or fourth, is determined by the beginning of the week. So in some cases, that week may have began in January, but ended in February. It's still a January week, even if it's just one day in that month. It's all about when it began. And we just said, yeah, we already talked about this, how they have to have it split. You can't use the same ordinality in 2 consecutive months. Now, here's the thing that'll help you. Even though it talks about that kind of pre-approval, and it kind of implies that it's done year by year, you don't really have to get it approved year after year. You can, instead of, you could submit the actual details and showing what day in that year you're using, what day in 2025 you're using, and then you could do it again for 2026. But what we're saying is if you get the structure approved instead of specific days, basically, if you say for January, I'm using week 1, February, I'm using week 2, so on and so forth, and we approve it, you can use that exact same structure next year without any sort of approval. If you change it, you have to get approval. But if you always stick with that same overall schedule, you're fine. And then you just translate it to 2026, for example. And if we have to audit this, we might request detail on what controls we have in place to make sure those time studies are done timely and accurately. That's just more of a description. So that is the time study documentation. I went into that in a little more detail. Nursing and allied health for cost reimbursement. Again, we talked about the managed care last requirements. And if it meets all those and some other criteria, it'll be allowed as a pass-through cost reimbursement, even for an acute care hospital, instead of being paid through the DRG. These are the lines where it's reported. You might have multiple programs requiring subscripts. It's important to know that those costs are split between two classifications. Your classroom time, before they start working on the floor, so to speak, that's your didactic time. And then the clinical training, which is where they might be doing more on the job type stuff, type training. Community support and this next one, I'm not going to spend too much time on these. These are two sections of the manual that CMS has reiterated that basically show, for this one, their intent way back when the program started was that they intended only to reimburse providers up until the point where the community starts funding the programs. In some cases, that's happened. And once the community has taken over funding through various programs, maybe nonprofits, anything like that, then Medicare is no longer going to reimburse. And it's a thing that once that happens, there's no returning, there's no going back to reimbursement. So they just reiterate that, and it kind of ties into this. Redistribution of costs means that they're only going to be allowing these costs if they're incurred by the provider, not by an educational institution, not funded by another party, anything like that. Only the costs that have not been funded in those manners or incurred by other parties would be allowed. Now, here's another topic that's right now pretty contentious. It's not so much this top topic, but the bottom. So requirement that CMS has of max is that we use A8 to make that adjustment to carve out the total revenue, the tuition, for example. And again, that is the total revenue, even if it's beyond the cost that you've reported for that program, which isn't all that likely, but it happens. If there is a remaining negative amount, it just drops off the cost report. You don't get that revenue doesn't offset something else. It just drops off the cost report. Now, again, this is the current instruction. There is a lot of contention on how this impacts your A&G allocation, which is based on accumulated cost. And that happens after you've done all your A6 and A8 reclasses and adjustments. So if you do an A8 adjustment, like we're supposed to right now, that can definitely impact how much A&G particular programs get. And that's the root of a variety of appeals that have happened on this issue that have challenged this A8 adjustment mechanism. And there's one that went all the way up to the DC Circuit Court, not the Court of Appeals, just the district court level back in 2024 or February of last year. The court did rule in the favor of the providers, but it's not the Circuit Court of Appeals, and it's too late to go there. CMS didn't appeal it. They're too late to do it anyways. So it doesn't have precedent value, formally precedent value. That being said, CMS hasn't changed the policy yet. I imagine they're thinking about it, what they want to do with that. The issue is that if the DC Circuit Court of Appeals sided that way with one provider, and if there's a very similar provider coming up, who's to say it's not going to say the same thing? And all this stuff is what CMS considers before they make a change in policy. So I don't really have an update here other than to say right now, unfortunately, we still do have to do the A8 adjustment. If that changes, if we get instruction from CMS, certainly we will do it differently. Provider operated status. This is one that definitely came up from CMS. It was in 2018. It was a big push. And I think possibly every MAC got hit by this in the quality reviews. I know we did, and I know at least some others did, because we read the regulation one way, and they didn't change the regulation, but they stated that their intent is different, and it's much more stringent than what it was being read as. So they issued a change request back in 18, and here's the link to it, that basically said, when you read this regulation, here's what we intend you to mean by it. It is what it is. I'll leave it at that. That's the change request. We have to follow it. We have a nursing allied health review questionnaire that walks through. It seemed like a change at the time. So it says, here are the requirements for the regulation for what you must meet to be a provider operated program, a legal operator. You have to directly incur the training costs, the provider does. You have to have direct control of the program curriculum, except for potentially some basic academic courses not related to the real degree or diploma or the program itself. They're just basic requirements. You have to control the administration of the program. And again, there might be some exceptions for limited things. You have to employ the teaching staff, and you have to provide and control both the classroom instruction and clinical training. So those two different things. Now, number one, here's where the confusion was. There's a bottom part that says, absent evidence to the contrary, the provider that issues the degree or diploma is assumed to meet all the criteria. So some people were reading and said, oh, hey, you have a degree, we're good. We don't even need to review these, we're assumed you meet them. CMS came back and said, no, that is absolutely not the case. And they kind of pointed to this evidence to the contrary. And they basically said the only way you'll get evidence to the contrary is if you review these in detail. So it kind of calls into question, why do they even use that? Again, it is what it is. Basically, what they now intend is that you have to meet these 5 criteria plus this degree, diploma, or certificate, assuming there is one. So that's where we've been since 2018. And if you don't meet those, you're not the legal operator of the program. But that doesn't mean you're necessarily out everything. It means you're not able to report your classroom or didactic costs, but you might still be allowed your clinical training costs. And the regulation, it's a different regulation that cites that. It basically says and I guess there's some precursor to that talks about how, yeah, you might be allowed this, but here's the limit. If there's any cost reporting period, or if any cost reporting period, the percentage of total provider cost for this clinical training to total cost, that cannot exceed the percentage that existed in the base year, October 1st, 1989. So first of all, if you didn't have this base year, if you didn't exist then, your limit is 0. You're out of it. But if you had this base year, we calculate that percentage and make sure that the current year hasn't exceeded that percentage. And there was concern when that was first pushed that if you read it, it almost sounds like, well, gosh, this is one of the requirements. So if you did exceed it, does that mean you're done? You can't report anything? Fortunately, CMS came back and clarified or restated their intent that no, it's just a regular limit. You're still allowed everything up to that percentage, and then whatever's past that percentage is just carved out. So that's a good thing. And here we have, so we have a question here. If all payroll is handled by the home office and those salaries are on the financial statement of the hospital, why does CMS consider that as proof that the hospital is not the legal operator? Yeah, it's a very good question. CMS has been very stringent and very specific on these types of things. Again, who knows if they'll change down the road, but when we've asked or when providers have asked, when appeals have come up on these things, they've required to every single letter of that regulation. And when they talk about control, when the home office is involved, that really clouds things up, and it's just not allowable. I wish I had a great explanation that said, "Oh, here's the reason for it, the justification for it." But right now, we just kind of have what they've written and what they've reiterated to Max time and time again when the home office is involved with that. Again, who knows if it might change down the road. And again, if appeals are filed, if appeals are lost by CMS, maybe that might change things. It's ultimately up to them, unfortunately. So you'd have a great question there. Wish I had a nice, perfect answer to wrap that up, but unfortunately, I don't. So now we are on to the miscellaneous topics, and these are pretty quick for the most part. We've talked about the RHC productivity standard and how it was discontinued for fiscal year ends. Didn't update the cost reporting software right after they took them away. And since this was fiscal years ending on or after 1/1/25, for example, you might have had a 1/31/25 cost report that needed to file their cost statement in June or their cost report in June. The cost reporting software wasn't updated at the time. So at the time, we were basically giving providers a workaround that, hey, just force a productivity standard exception. You don't have to necessarily go through the formal approval. Just plug in a 1 for that minimum number of visits, and then it goes, there's no reduction. Fortunately, and we at the time, we also said that even if you didn't do this workaround when you filed the cost report, we'd catch it at final settlement and do it. Fortunately, CMS has updated the work instruction to completely close that productivity standard, so no workaround is needed. If you happen to use the workaround, it's closed. It doesn't matter. So fortunately, that's gone. Here's S-8. Have you received an exception? There's no open cell there. I don't think, yeah, I don't have M-3. That's the next topic we'll talk about. But again, it's closed. So no need to worry about that. A quick update about the consolidation issue. They also updated the worksheet S8 and S8, I'm sorry, just S8 for the consolidation question. We talked about this last time as well. We said after multiple rounds of clarification from CMS, they came back and said providers or these RHCs in a hospital can consolidate into 2 potential groups, no more though. And they don't need to consolidate. They might use one consolidated group, and then the rest of the other types of RHCs, they might not decide to consolidate. So it's all about non-grandfathered or leave them all separate. Every consolidated group, by the way, and every individual RHC has to fill out this S8. It's the control worksheet. If they are consolidated, then there's a new indicator here, whether it's G or N. N is non-grandfathered. And again, you'd list out all your non-grandfathered RHCs here. If you had another group of grandfathered, you'd have a separate worksheet S8. You'd answer G in that case because it's grandfathered, and you'd list all your grandfathered RHCs out. Those are the ones that had a base year in 2020. If it had a base year in one of the later years because they had short periods, those can never be consolidated into anything. That was the CMS clarification that was most recent. Now, this doesn't impact the flow. It's just setting up the stage for how the other worksheets are going to be filled out. All the M series for every consolidated group. So this is the only thing I wanted to mention as an update for consolidations. Not a major change. The RHC vaccines. CMS published RHC per visit limits. That's a good, I don't think I have that offhand. I can certainly include that in the email though. I know where to find it. I just not quickly. I have it in my list of notes, so I can definitely give that for you for the grandfathered ones. So for the grandfathered ones, those aren't actually published. Those are developed by the base year cost report. If you're talking about the non-grandfathered ones, I can point you to those. That's in a publication. But the non-grandfathered ones are calculated by each MAC, and the information should be sent out via letter when that calculation happens. And then again, every year it's inflated forward by the we have total and Medicare vaccines, and we're trying to prorate or trying to apportion the amount of that total vaccine cost that relates to your Medicare patients. That's the intent. Worksheet M-4 historically has reported all the individual vaccines and then a grand total. I'm going to say that's changed now, and I'll explain in a bit. Total, or line 11 has you report the total injections for each type. Line 13 reports the number of injections just administered to program beneficiaries. This is Medicare. We're talking Medicare for this case. And that's all we're concerned about on this side. Now, there's a 13.01 that says the number of COVID-19 vaccine injections administered to MA, Medicare Advantage enrollees, Medicare Part C, if you will. That's separate from what we reported on line 13. By the way, there's one important phrase here. These are allowed for cost reimbursement when the RHC patient is not simultaneously a patient of the hospital, so at the same time there. If they are at the hospital, they're reimbursed through the normal hospital payment, and as we'll see in the instructions, you're not supposed to report these here. That's duplicate reimbursement. So the first question we've had pretty recently is Medicare Advantage included in that program beneficiary's term? The general answer across the board, whether we're talking about bad debts, whether we're talking about GME, IME, organ, anything, the general answer is no, unless there's a specific inclusion in the instructions. There might not always be a specific exclusion, but it's a general no unless it's included in the instructions. Line 13.01 has a specific inclusion, but it's a limited one for 2020 through 2021 and only for COVID-19 injections. So that's 13.01. It goes into great detail of separating that out and saying it's allowed for MA enrollees. Line 13 does not have such. And Medicare Advantage should not be included up here. If it's reimbursed, it would be reimbursed through your Medicare Advantage plan. And again, it might not be reimbursed at all. It's up to the plan you have, but it won't be reimbursed for Medicare on the cost report. Now, of course, for total vaccines, we need a log. There's no other documentation we could have. But for Medicare vaccines, which is a subset of that total, there's the PSNR. If you build the claim, we can see it in the PSNR, and we know that that number needs to be reported there. So the question we've had recently is, well, was that billing of the Medicare claim required, since you can just report the number and it'll get reimbursed at the end on the cost report? The only way to get an interim payment is to bill the claim, and it'll be reconciled at final settlement. But that billing also serves to document that, yes, it's indeed a Medicare entitled patient and not Medicare Advantage, for example, which would be a separate report. So that's been a question for a little while. If you go to line 13, which is where Medicare is reported, they made a change July 1st, 2025, and there was actually a MedLearn Matters article on this. And now it says, or before it, it says from your records or the PSNR. So your records would be the log or the PSNR. You could bill it, it'd be in the PSNR. On or after July 1, 2025, cost report periods beginning at that point. Where does it say it? From the PSNR. It says enter the Medicare injections from the PSNR. It no longer gives that possibility of using your records. So it's pretty clear now it must be billed on or after 7/1/25. I know there's some confusion or some ambiguity because the MedLearns Matters article didn't seem to have a very stringent requirement that you must bill. This cost reporting instruction policy does. It says they must be, or it says from the PSNR. The other thing about this is that you no longer have to separate it out. You can just report total of all the vaccine types. You don't have to separate it out between those earlier columns. The other issue with that is that the patient cannot be in the hospital at the same time, and that's at the very top of worksheet M-4. Let's see. Additionally, only use this worksheet for vaccines rendered to patients who, at the time of receiving the vaccine, were not inpatients or outpatients of the hospital. If they are simultaneously inpatients or outpatients, they're reimbursed through the hospital and cannot be claimed by the hospital-based RHC. That's something CMS has stressed a little bit there as well, that, hey, we need to make sure that vaccine is not an inpatient or outpatient. They were questioning how we were documenting that in one of our quality reviews. So we have, a couple ways to test it. And by the way, it's at the same time, not necessarily on the same day. You could have a hospital patient that got discharged from the hospital and then later that day went to the RHC and got a vaccine. There's nothing wrong with that. It's not at the same time. If it's on the same day, of course, there's a little bit of red flag, and we'd have to dig deeper to make sure it's not at the same time. So if we come across those situations in our review of the claims documentation or the log itself, we would be asking questions at that point. So that's just the thing there. It's actually a new review protocol that CMS has brought up, and just the past couple years, I guess. And again, in quality reviews, they've had questions on how are we following that review protocol? How are we documenting it? So they're pushing a couple different levels for that. Pretty quick response for this low volume MDH extension. These in red I had to update from the PowerPoint that you might see. These are the correct ones. The low volume and MDH were extended to 9/30/25, but then they terminated. There was no legislation at the time to extend them. The Federal Register went into detail about that, and it said, hey, normally you have a 9/1/25 due date for the annual request. When I say terminated, by the way, for low volume, it terminated the new criteria, and it reverted back to the old original criteria that were in place from 2005 to 2010. They're much more stringent. Very few national hospitals provided or qualified for it. So that's where we were as of 10/1/25. So the Federal Register, they were basically saying if you don't qualify for those old criteria, then none of this matters to you unless Congress extends it. The 9/1/25 due date was for the few hospitals that could still qualify with fewer than 200 total discharges, greater than 25 road miles to the nearest hospital, and they get a payment of 25%, an add-on payment. The temporary revisions, and I have the detail about the older temporary revisions. For the past few years, it's been you have to have fewer than 3,800 total discharges on S-3, column 15, line 1, and you only have to be greater than 15 road miles to the nearest hospital. It's a sliding scale, anywhere from 0.0076% to 25%, depending on just how few discharges you have. Fortunately, there was another piece of legislation that extended it. I have it listed here. They extended it only to 1/30, so a few months from 10/1 to 1/30, and we'll have to see if we're in the same mess in a few months. Now, here's the thing. It's potentially retroactive to 10/1/25 if the application was received timely. We are right now awaiting that CMS change request, implementing this first of all. And at that point, we'll have all the details. we've requested, even as far back as August 6th, that if a provider thinks they qualify, go ahead and send that application in early so that we can get moving on it if Congress extends it. That way, now we can get working on it, but we can't formalize it and finalize it until CMS issues the CR. I'd be quite surprised if they don't get it out either this week or next week before the holiday. I'd be pretty surprised if they don't, because it's an important issue. And I've been following up with providers that previously qualified and hadn't submitted anything from our 8-6 reminder, and a lot of them have already submitted. If you know you qualify and haven't submitted anything, I just suggest you get that in quickly. We don't formally know what due date CMS is going to put in for that, but historically it's not been a very long time. It's been a very quick turnaround. That's why I tried to do this early. By the way, I know we're at the hour. I just have just a couple minutes if you can hold on with me, or if you need to leave, that's perfectly fine. But I'll wrap this up in a couple minutes. We'll be sending out the instructions. We've got the letters in process right now. As soon as we get the change request, we'll update the website. We'll send out the letters and reprocess claims when applicable. Here's the address for the requests. A couple links. Oh, this is what I was pointing out earlier. These are just our resources. We have the WPS website. We have our YouTube audit playlist. And here are some of the articles, or the website articles we've updated since our last webinar. I'm going to be going this route in the future just to show you really the things that are newer, so you know what to maybe take a look at if it applies to you. And then the other big changes for our webinars, I'm now going to be pre-scheduling these, and I'll try my hardest to stick with these dates. That way you'll know ahead of time if you want to attend, when about will it be. And I'm even going to go so far as for our contact list, just to get it on your calendar, you'll be able to do so early. I'll also send them out when we're closer to that time, but I think this is just a cleaner approach. And I know I took 2 extra minutes of your time. My apologies for that. But are there any final questions before we wrap up our session today? Okay, well, I'm going to post the survey link one more time for those of you that would like to take that, or can take it, I should say, if you're not a MAC contact. Again, thank you very much for your time. Hopefully you had some good information from this that might help you. If you do have any other questions, you can certainly follow up. And again, those surveys, if you put any feedback, any topic suggestions, we certainly appreciate that. So thank you very much for your time. Have a great lunch and afternoon, and I'll talk to you in the next session.